right, I'm going to go ahead and get started. So this is my PEM CCM lecture. All right, so I'm Christina. For those of you who don't know me, I'm one of the PGY3s. Huge thanks to the CCM team and the PEM team for helping me assemble this conference. This lecture. So we're going to start. So at 13:38, the patient arrived by mass transit. This is the first triage note that went in at 13:43. The mother states the child has been very
Christina, sorry,
Sorry,
Christina, we only see the you're not going through. Yeah, there you go.
Is it going now?
Yeah, I see the first slide, pre-hospital history.
Yes.
Okay.
Okay. It says my screen sharing is paused. I'm not sure why. Let me see if it keeps advancing. So this was the first triage note. The mother states the child has been very sleepy, not eating well for several days. The child was just seen at an outside hospital, is otherwise alert and awake. All right, so at 13:58, the first set of vital signs go into the computer. They're normal initially, and there's no finger stick reported at this time. Of note, on chart review, patient was seen in the ED at an outside hospital a few weeks ago. And at that time had a fall, was reporting right lower extremity pain and weakness, got x-rays done that were all unremarkable, was not ambulatory afterwards, but was still discharged home with ortho and PCP follow-up. And now at the outside hospital visit just the day before presentation, the patient had come in with a chief complaint of not ambulating over the last 2 to 3 weeks. On physical exam, they noted that patient had a head circumference of 52 centimeters with the prominence of the anterior fontanelle. On the physical exam, they note that the patient was not cooperative with eye exam, was able to stand but refuses walking, did not know any focal neurodeficit. The discharge diagnosis was macrocephaly. And despite the notes saying kind of weighing to do a CT head versus an MRI, ultimately no imaging was performed. The patient was given urgent outpatient referral to Kings County and was ultimately discharged. So on further HPI, you note that the chief complaint is fatigue. Patient's been sick for several days and very lethargic per mom. This is a 28-month-old male, has had 2 weeks of not ambulating at baseline, has basically stopped walking. And then 1 week ago, mom noted that the left eye was unable to look laterally. And a few days after that, patient started to have repeated emesis upon awakening, had a headache, been crying anytime anyone touched his head, and then today stopped speaking, was only able to make sounds, babbling, holding his head, crying in pain. Review systems was negative for any fevers, any seizures, any other GI complaints. So on further medical history, you find out that this patient's pretty healthy, 28-month-old, has had prior otitis media and viral illness in the past month, but no hospitalizations, doesn't take any medications, doesn't have any surgeries, doesn't really have any kind of like remarkable history. On further questioning, you find out that the patient was born in Central America, was full term, didn't have any NICU stay, no complications during or after pregnancy. Developmentally, he was walking at 1 year of age, was running at 2 years, and as of late has been speaking 1 to 2 word sentences, no speech delay, no previous ocular abnormalities. His vaccinations are up to date. Apart from immigrating to the US 3 weeks ago, no other travel history and no relevant family history. So on initial assessment, you know, the ABCs are intact. The patient's awake, but does have a visibly enlarged head with tenderness to palpation over the crown of the head. His left eye is deviated medially, and the right arm and leg are extended. There's no posturing, but the legs kind of naturally fall in extension on that right side. On further physical exam, you note that the child is crying, sitting in the stroller, holding his head, not speaking, only sounds. The head is enlarged with sutures bulging and some tenderness to palpation once again over the crown of the head. Patient's tachycardic, but otherwise unremarkable cardiovascular exam. Respiratory and GI exams are normal. On neuro exam, you note that the left eye is medially deviated. It does not track laterally. You do note some horizontal beating nystagmus, and the right arm and leg are straightened. You're able to flex passively. There's no hypertonicity, there's no clonus. The gait was not assessed at this time. So based on this, what are some of the preliminary problems that you can think of? Anyone?
Anyone?
Someone
Danielle.
give it one.
Danielle? Where's everybody?
So we have a patient that is unable to walk. They have like obvious neuro deficits. It's been going on for at least 2 weeks. Definitely concerned that there could be some like intracranial process of there. It doesn't seem like it's infectious based on the vital signs, but could be like a mass or yeah, like there definitely needed to be imaging on that first visit at the outside hospital. And also it's kind of strange to discharge someone if they're so deviated from their baseline, especially because outpatient imaging doesn't happen right away.
Awesome. Thank you, lady. So preliminarily, we have some neuro exam findings. This patient's not acting at their baseline. You have the bulging fontanelle, and some tachycardia. So based on this kind of, and Lady already touched on this a little bit, your initial interventions are probably going to include some sort of imaging to assess for any sort of neurologic etiology of this. So on your first image, you end up getting a ultrasound. You throw the probe on the well, not throw, but you place the probe on the patient's head, and you're seeing just a lot of anechoic fluid on this. So what might you be concerned about right now? Anyone other than Lady?
Abner.
Can you play that again? I didn't see what structure is that.
Yeah, so if you're just looking at the head and you're seeing a lot of anechoic structure.
Yeah, so you can, that might be concerning for maybe hydrocephalus.
Exactly. So right now we're kind of thinking, okay, this might be increased like hydrocephalus that we're worried about. So at this point, you're consulting neurosurgery and you really want now your CT head. At this point in the patient's workup, you're sending your pre-op labs, you're putting in your IV. Patient at this time was still protecting his airway, and there were no the finger stick at this time was then 147. He was placed on a monitor. Tylenol was given for his pain. And then, let's see. So like we were saying, so now at this point, we're having hydrocephalus, and kind of like what Lydie was already outlining, there's not really any suspicion of an infectious etiology given. Patient didn't come in with a fever, so like less likely that it's more of like a meningitis type picture. And then as she mentioned, could be something like a brain mass, which could include something like an astrocytoma, a craniopharyngioma, germ cell tumor. And then we don't really have any history that's immediately pointing towards a traumatic etiology. So we get the CT head. And this is what it shows. So the initial read on the CT head is a large suprasellar cistern mass, 3.9 centimeters, causing significant mass effect on the third ventricle, which is partially distorted and otherwise dilated, as well as diffuse dilation of the lateral ventricle with transepidermal migration of CSF, consistent all with obstructive hydrocephalus. Appears to be some sort of cystic component of the tumor as well. So at this point, you're consulting your neurosurgery team and you're consulting your PICU team as well. So the neurosurgery team is obviously concerned about the hydrocephalus. They want transfer to a facility with pediatric neurosurgery. PICU also agrees that this patient really needs to be transferred immediately. So continuing the ED course, the patient's systolic blood pressure begins to increase, now is over in like the hundreds and becomes a bradycardic. Definitely a change from their kind of baseline vitals that they came in with. By 15:30, neurosurgery is at bedside. They're attempting to drain the CSF, doing a ventricular tap. And during this, they had kind of taken multiple attempts going right through to try to actually get, using like a spinal needle to actually get at the fluid. During this, at 1600, patient has what appears to be a seizure and then develops decerebrate posturing. By 1605, patient's bradypneic, but there's no change in the SpO2. So at this point, what's kind of your next step? What's something that you think needs to happen?
Patient needs to be intubated.
Exactly. So at this point, we are preparing for intubation. We've given lorazepam, 2 milligrams for the seizure, which is already resolved, and preparing for intubation. And patient was given 3 milligrams of etomidate and 10 milligrams rocuronium. And at that point, the intubation was attempted using video assisted and bougie assisted. Ultimately, the tube was placed and confirmed with ETCO2 detector, and bilateral breath sounds are heard. Additionally, you're now giving Keppra for your neuroprotection. So it's given 430 milligrams and 10 of dexamethasone for mass effect, and given fentanyl 20 micrograms post sedation, as well as hypertonic saline running at 54 cc's an hour. Chest X-ray was done, NG tube and Foley were placed, and the tube is confirmed on chest X-ray. This time, the patient is now getting transferred for pediatric neurosurgery. So ultimately, you had a patient with obstructive hydrocephalus and acute respiratory failure, now intubated. So we're going to go into a little bit more depth into some of these management of the neurocritical patient. So first, we're going to kind of discuss a little bit of the intracranial pressure and then initial resuscitation, go over some airway management, medical therapies, and surgical interventions. So let's first talk about intracranial pressure. So the Monroe-Kelly doctrine essentially says the brain's an enclosed space that can't expand. So there's got to be equilibrium between the partial pressures of the brain parenchyma itself, the CSF, and both venous and arterial blood.
Christina,
Normal.
I'm sorry to interrupt. I don't think your slides are moving. Okay, now
Oh, did it stop again?
yeah. The slide that we're seeing right now, it says let's talk about intracranial pressure.
Okay. That should be the slide you want to see. So with this, normal ICP in adults is 5 to 15 millimeters of mercury. And in this diagram on the left, you're looking at the increase in volume that's causing mass effect. So anytime that you're going to have a mass, you're basically pushing out kind of your space to have other room for your venous, your arterial volume, and your brain and CSF volume itself. looking at the diagram on the right, you're seeing hydrocephalus, which is going to increase and once again still further kind of push out your other actual space for all the other contents of the brain itself. So any kind of lack of equilibrium is going to lead to hypoperfusion and ischemia and potentially herniation as well. So how do we manage the elevated ICP once we know that it is elevated? So a 2023 review looked at various treatment guidelines and expert opinions in order to try to come up with an organized evidence-based approach to the recognition and management of patients with either suspected or confirmed elevated ICP. This was really looking at what you can do in the first minutes to hours of resuscitation. So these are some of the findings. So in terms of how you know whether the ICP is even elevated, yeah, you can look and the patient may be altered. They may have a history of a headache, vomiting, but these are really not specific findings. So a systematic review and meta-analysis done in 2019 by Fernando et al. Found that pupillary dilation and GCS less than 8 along with the Cushing triad are really good markers of raised ICP. So when we look at the likelihood ratios circled in red, it's basically saying that there's a high chance that a patient with either these pupillary dilations or the GCS less than 8, really good chance that they actually do have increased ICP. And then when we think of, obviously with the GCS of less than 3, even with that, you're going to also see kind of an elevated likelihood ratio. So when we think of what we're going to see on imaging that's going to point us toward an elevated ICP, the most sensitive sign that we're going to see is the basal cistern effacement. It has an 85.9% sensitivity, along with midline shift, which is an 80.9% sensitivity. So when we're looking at this, we're basically seeing that with this space occupying lesion, we get effacement of the ventricle itself, and then we get where the basal cisterns should be. And so we're no longer seeing those structures as clearly. And then obviously with the midline shift, we're getting that and seeing that more clearly on imaging. Both of those are pretty sensitive for raised ICP. The other thing you can look at is what's called the Marshall classification, which is basically a grading system using key findings of CT neuroimaging to prognosticate TBIs. So basically a higher number of Marshall classification leads to a worse outcome for the patient. So looking kind of at other things that we can do. We can look at the POCUS to look at the optic nerve sheath diameter. So there was a systematic review and meta-analysis done in 2019 by Koziars that found that optic nerve sheath diameter is highly sensitive at 92% and specific at 86% in diagnosing elevated ICP. Had a positive likelihood ratio of 6.93. So this is like a high chance that a patient with increased optic nerve sheath diameter has increased ICP. And so this is based on the notion that increased ICP should be reflected in the dilatation of the optic nerve sheath. So what you end up doing is you measure the optic nerve sheath diameter 3 millimeters behind the eye. Less than 5 millimeters is normal. Greater than 6 millimeters is consistent with an elevated ICP. Problem is between 5 and 6 is kind of a gray zone. So it's a little unclear what you do with that. Well, the point of care ultrasound for the optic nerve sheath diameter, it can be helpful. It can give you additional information, but it can't really be used in isolation. So what about more invasive intracranial monitoring? So there's kind of conflicting evidence that invasive monitoring improves patient outcomes. So when we're talking about what you can do with invasive monitoring, we're talking about an intraparenchymal sensor, so something that's actually going into the brain parenchyma itself, versus an external ventricular drain going into the ventricles. So the benefit of an EVD is that not only can you actually measure the ICP more invasive, but you can also drain fluid off. So it allows for an actual intervention. But most of the data kind of looking at the invasive intracranial monitoring are from non-randomized control trials. They support invasive ICP monitoring, citing improved recovery, but some of the evidence of it is actually mixed. One of the hallmark trials that they've looked at was called the Best Trip trial. So it was the benchmark evidence from South American trials for the treatment of intracranial pressure. It was an RCT that looked at patients with severe TBIs to see if invasive ICP monitoring compared to non-invasive CT imaging and clinical exams reduced mortality and improved neuropsychiatric and functional recovery at 6 months. The invasive ICP monitoring that they used was an intraparenchymal monitoring. And they were trying to maintain ICP less than 20. So this was 324 patients that were enrolled, but this was also a population of patients who had suffered traumatic injuries, mostly secondary to traffic incidents. They found that there was no improvement in neurological outcomes or mortality in the invasive ICP monitoring group. But the problem with this study is it was done in South America, so kind of generalizing to the US, it doesn't have the greatest external validity. There's kind of different levels of care that are done and not kind of the same pre-hospital care. So for a lot of these patients, some of the more severe TBIs might not even make it to the hospital to undergo any kind of intervention. The other thing that was an issue with this study is none of the patients actually received rehab or extensive medical care after discharge, and the elderly were not represented at all in this population. And kind of the bigger thing being that EVDs were not the invasive intracranial monitoring technique used in this study. And it's important to realize that even with the invasive monitoring, it does pose its own risks. You have an increased risk for infections, post-procedural hemorrhage, you can misplace the actual monitor in the wrong area of the brain, and so it's not without its risks. So once we know that the
Christina,
ICP...
can I
Yes.
just say, for some reason, my mic wasn't working. I had to go back to my settings, so I couldn't speak. When you were talking about the ultrasound,
Yes.
right, if you want to go back, I just want to highlight that more important than the actual measurements is that cupping of the optic disc. That is going to be more pathognomonic of intracranial pressure than the numbers itself, because the numbers are really, we're extrapolating them for children. They haven't been studied in kids. So if you see that cupping of the optic disc, if you want to point that out for everybody, that's more specific for increased intracranial pressure.
All right. And then big things with once we know that the intracranial pressure is elevated, our next steps are kind of how are we going to manage it? Now, this list is not a list in order of priority, but it is a list of things to take into consideration once you do note that there is rising intracranial pressure. So positioning the patient is important because you want to promote cerebral venous drainage. So having the head of bed 30 degrees, having the neck midline, it helps to relieve the jugular venous compression. And then you really want them to have normal blood pressure. So you want to keep it between 100 and 180 systolics. So that might mean you need to use labetalol to kind of bring down any elevated pressure. And you also want to be preventing hypotension, which you might need some sort of norepi to kind of keep their pressures up. You also want them satting above 94%. You want their temperature between 36 and 37.8, just for optimal functioning of the rest of their organs. When we think of protecting the airway, I'm going to discuss that in more detail on the next slide, but you really also want to avoid like noxious stimuli such as excessive tracheal suctioning when you can. And then you really want to treat their pain, their agitation, any anxiety. All of these can cause increases in ICP, and you want to decrease the metabolic demand. So you can use things like fentanyl, ketamine, Precedex, propofol, to kind of help to treat those symptoms as well. And then any kind of nausea or vomiting, you also don't want any risk of aspiration. So you can use Zofran as well. And then you're going to ultimately want to reduce that cerebral edema. And so we're going to talk more about how we would go about reducing that in a couple slides. So in terms of intubation, these patients, they may be unable to protect their airways, or if they're kind of entering the Cushing trial, they may just have impaired ventilation. But intubating for neuroprotection, you have to remember that any kind of airway stimulation of intubating itself, it can increase heart rate, it can increase blood pressure, it can induce bronchospasm, and even the induction agents themselves can cause hypotension. So these airways can be difficult. So in terms of your pre-oxygenation, you can also pre-treat with fentanyl a couple minutes before induction, or other short-acting opioids to help with these increases in heart rate and blood pressure. But it is unclear how much this actually improves patient outcomes. When you're thinking about your induction agent, you want a hemodynamic agent that won't cause hypotension. So more recent studies have shown that although there was a concern that ketamine could raise ICP, larger systematic reviews have shown little evidence to support this. There doesn't seem to be any difference in mortality or patient outcomes when you're using ketamine versus etomidate. And then in terms of your paralytic, succinylcholine had similar concerns about raising ICP, but newer studies have not shown that. And it's beneficial to use sometimes because it's doesn't last as long. So you can do a further like neurologic assessment sooner after using it than you might be able to do with something like rocuronium. So when we're thinking about reducing the cerebral edema, we're thinking about our hyperosmolar therapies. So these work by, one, expanding the plasma volume and reducing the blood viscosity, which in and of itself improves oxygen delivery. And the other way these work is they create an osmolar gradient. So at the blood-brain barrier, the blood's going to draw in the water, and that is going to reduce the ICP. But of our agents, we have both hypertonic saline and we have mannitol. So it becomes which one are we going to use? So there was a 2022 systematic review and meta-analysis done that looked at the efficacy of hypertonic saline in managing elevated ICP, as well as in lowering mortality rates and improving neurological outcomes in patients with TBIs. Now, in this case, we're talking about TBIs versus elevated ICP secondary to non-traumatic events. But this did look at 8 studies, including 3 observational studies and 5 with a clinical trial design. All of these were conducted from 1998 to 2018. And what they found is that hypertonic saline does reduce ICP with a 35.9% reduction in ICP. And there saw similar efficacy of mannitol and hypertonic saline in several of these studies. There was a lower ICP burden in the hypertonic saline group in both the Chang study as well as the Violette study. And then the study at the bottom by Schatzman showed that hypertonic saline decreased ICP effectively, and the neuro outcomes and mortality rates were not significantly different, even when looking 6 months out from the actual TBI. The duration of ICU stay was also not significantly different. So the recent systematic reviews comparing hypertonic saline and mannitol found no superiority of one over the other. But that being said, mannitol itself can cause hypotension through its diuretic effect. It can also lead to poor glycemic control, whereas hypertonic saline, if anything, has been reported to have a prolonged reduction of ICP, lasting about 120 minutes. It is also easier to dose and can be repeatedly given. So that being said, you still got to think about what are your availability of hypertonic saline versus mannitol, what's kind of the clinical picture in front of you, and what are the circumstances leading up to this. Like I said, this was a study done in TBI specifically. So when we're thinking about what kind of surgical intervention we could do, there's the decompressive craniotomy. And so it becomes the question, is this something we would want to do? So there was Ardicino et al. Did a systematic review of the current methods of surgically managing a pediatric TBI. It looked specifically at this decompressive craniotomy in reducing ICP short-term, as well as improving rehabilitation outcomes long-term. This was an analysis of 12 studies. One was an RCT and 11 were case series. There were about 260 patients enrolled in these studies. And what they found was that ICP was reduced using the surgical intervention with fewer ICP additional interventions needed, meaning that once they did the actual surgery, they didn't also have to use a lot of other agents like hypertonic saline and mannitol to further reduce the ICP. In the study by Cho at the top, they found that 80% reduction in ICP in the patients that underwent the surgery. This was a significant value. Mortality was also significantly lower in the surgical group. Whereas in the other study, Joseon study also noted that they were seeing higher survival rates. And then the other study that they really highlighted was study Taylor et al., which is here, and it was showing that the surgical intervention led to better ICP control than medical therapy, but it wasn't a statistically significant difference. When they were looking at positive outcomes versus negative outcomes, they characterized complete recovery or only mild disability as a positive outcome. Severe disability, dependency, vegetative state, or mortality, those were all listed as negative outcomes. In the Cho et al. Study, they found that there were more significantly positive scores 6 months to 6 years after undergoing the surgical intervention. So with this, the ICP seems like it is well controlled with the surgical intervention in the short term, but with these studies, you have to also take into account these were small sample sizes. There's not a great quality of evidence regarding these surgical interventions because it's very hard to really study this. And so they found that there is some evidence that it's worth doing when you're also undergoing other surgical procedures, such as hemorrhage evacuation, or when you're suspicious that the patient might be herniating, or that their ICP just keeps on increasing with signs of neurological deterioration. Then it might be worth considering this. But otherwise, the literature kind of assessing it isn't great to really figure out whether it's a good intervention or not. Looking at this additional study, was a study by Wang et al. In 2015. This was also a systematic review and meta-analysis of several RCTs. And it was looking to see if early surgery significantly improved ICP control and overall mortality. In this study, 8 studies were looked at. 3 were RCT trials, 3 were retrospective, 1 prospective, and 1 case control. There were a total of 256 patients, but this was also done in a trauma population, so can't really fully be generalized to non-traumatic etiologies of ICP raising. The other what they were finding in the results of this is that the overall mortality from the surgical group ranged from anywhere from 0% to 65%, with a huge range. Those with favorable functional outcomes ranged from anywhere from 14% to 71%. Patients who underwent the surgery had half the risk of death compared to those who did not get a surgical intervention, but this was not a significant finding. And there was a significant reduction in ICP in the surgical group, as well as the hospital stay was 10 days less than in the surgical group. One of the studies that it's looking at is the DECRA study, and this is the Cooper et al. Study. And what they found in that study is it's the decompressive craniotomy in patients with severe TBI trial. It was run from 2002 to 2010. It looked at adults with severe TBIs and intracranial hypertension refractory to meds, and it compared surgical intervention versus medical therapy. And the surgical intervention group did have a shorter time of having raised ICP and required fewer interventions to reduce the ICP with fewer ICU days. But the major thing that they looked at was the Glasgow outcome score, which is similar to the Glasgow coma score, except that a higher score is, except that it's looking at ultimately the outcomes up to and including death. So a score of 1 would be death, and a higher score is a better outcome. And what they found is that they did have worse of these Glasgow outcome scores, despite having shorter ICU times and less amount of days with raised ICP. One of the things that was criticized in this study was that there was an unbalanced cohort. So many of the more severe TBIs ended up in the surgical group. So it's hard to say whether they had worse outcomes because of the magnitude of their injury versus the intervention itself. One of the other studies, Q et al., also looked at patients with acute post-traumatic brain swelling and compared the surgical intervention to the non-surgical intervention. They showed greater ICP lowering with surgery and lower mortality, and found even good neurological outcomes 1 year later. And then lastly, the Taylor et al. Study looked at 13 pediatric patients with TBIs who got surgical intervention compared to 14 who did not. They found a larger mean reduction in the ICP in the surgical group at 48 hours with significantly lower mortality rates. So in summary, the patients may benefit from a surgical intervention, but it's not clear which patients will benefit the most. And patients who undergo the surgery, they may have higher ICPs to begin with. And so they might end up being placed in the surgical group because they require aggressive intervention. And so once again, you're not sure whether their outcomes are more related to the magnitude of their injury versus the actual intervention being looked at. There's really, once again, few high quality studies out there looking at the surgical intervention. And one of the really big issues with this study is that the ICP was not always measured at the same time. And so it's hard to kind of generalize based on these studies whether this really is a good intervention to do, especially with such low sample sizes. So let's kind of move back to our patient. So after he was transferred on hospital day 0, he went straight to the OR and got EVD placed. On hospital day 1, the MRI showed both cystic and solid suprasellar mass with still continued severe hydrocephalus. On hospital day 4, he underwent a craniotomy and biopsy. A repeat MRI done later that day showed improved ventricular megaly and midline shift. On hospital day 5, he underwent a VP shunt and was ultimately extubated and downgraded to the floor. By hospital day 8, he was discharged on a steroid taper. And then about 2 months later, he underwent a biopsy, or the biopsy results came back showing a pilocystic astrocytoma. He started chemotherapy. And then about 2 months after that, he was seen in a pediatric clinic and showed an improved gaze deviation, speech, and gait. So kind of in summary, there's a lot of different ways to assess for rising ICP. You can use exam findings, you can use imaging, you can use invasive monitoring. You always want to come back to your ABCs. These patients can be very critical, and they can also, like in this particular patient, they can decline pretty quickly. And so you always have to be thinking back to your ABCs. Now, hypertonic saline, based on the studies, looks like it is the drug of choice for TBIs, but that doesn't necessarily mean it's always going to be the drug of choice that you want to use. If you're interested in more of like a prolonged ICP lowering, it can be beneficial. And if the patient's really more hypotensive and you're worried about glycemic control, you do have the option of doing that over mannitol, and it is favored in those particular situations, but you'll ultimately want to look at the clinical picture of the patient in front of you. And then in terms of a decompressive craniotomy, these really the only thing that it seems that the evidence supports is if you really have a patient who's got refractory intracranial hypertension, or at this point they're really at risk for herniation, and this really might be kind of the best solution for them, but that's obviously going to be a choice that you make in conjunction with your neurosurgical team. And that is everything.